Hello, everyone, and thank you for joining us today for the Let's Talk Menopause and Continence webinar being held as part of the Gina Howells Women's Health Week. I'm Janie Thompson, National Continence Helpline Manager at the Continence Foundation of Australia, and I'm also a woman in her menopause year. Today's webinar is supported by funding from the Australian Government under the National Continence Program. And I'm really excited to have so many people attending this webinar today because it is a very topical webinar and something I'm personally going to get a lot out of. We would like to acknowledge, just to acknowledge that the viewpoints presented by the speakers today are their own personal viewpoints, and we would encourage everyone to get professional advice with regard to their own personal situation. Next slide, please. We'd like to acknowledge the First Peoples of the beautiful lands on which we are meeting today and celebrate their enduring knowledge and connections to country. We honour the wisdom of and pay respects to elders past and present. Okay, I'd like to introduce you to the Continence Foundation of Australia, who I work for. You probably are aware of the foundation. We have an amazing website that you can visit to see lots of our resources, which are free and available to people, including topics related to menopause, women's health. I also would love to introduce our two speakers today. We have Bronwyn Ford, a woman with lived experience with perimenopause, menopause and continence, and Libby Oldfield, a specialist women's, men's and pelvic health physiotherapist. We'll also be having a question and answer session at the end of the presentations by these two amazing ladies. And I'd really thank everyone for submitting questions for today's webinar. We've had over 100 questions, and we've tried to sort of figure out which are the ones we are most relevant and most similar questions, but we won't be able to answer all of them today. But yeah, as I said, we're looking at some themes. So as I mentioned, the Continence Foundation is the peak body for bladder and bowel health throughout Australia, and we work to improve continence health for people living with continence in Australia. Next screen, please. So I don't know if you've ever heard of the National Continence Helpline. So we've got another little poll to actually find out what you know. So have you heard of the National Continence Helpline? Yes. When I registered for this webinar or during the webinar, yes, generally, or no. So I'm really interested to see if you have heard of the National Continence Helpline, because I know we do amazing work and are a free and confidential advice line available to all Australians. So the National Continence Helpline is staffed by nurse continence specialists, and every year we speak to about 20,000 people throughout Australia. Our number, as you can see on the screen, is 1800 33 0066, and we're available from Monday to Friday, 8 a.m. till 8 p.m. Australian Eastern Standard Time, and then also Australian Eastern Daylight Savings Time. We provide advice, information, and there is also access to a large range of continence resources and also information on local continence services, because we've got quite extensive directories on continence services and also continence products. Oh, good. So I'm really excited to hear that majority of the people on the webinar today have heard of the National Continence Helpline, which is fabulous. And just to let you know also, the helpline is funded through the Australian Government Department of Health. Now I'm going to have a great opportunity to have a chat with Bronwyn now. As I mentioned, I'd like to introduce Bronwyn. She's a lady with lived experience of menopause, perimenopause, pelvic organ prolapse, birth injuries, incontinence issues since the birth of her two children. Her personal experience has enabled her to advocate for herself and for other women with similar experiences. She raises awareness by sharing her journey and advocates for better support and information and education. Bronwyn is also a member of the Continence Foundation of Australia Continence Consumer Network. Welcome, Bronwyn, and I'm very excited to speak with you today. I'm going to ask you a few questions if that's okay, Bronwyn, just to get a bit of an insight into your journey when it comes to menopause and continence. So could you tell me what changes you noticed to your bladder control during perimenopause and menopause?
During perimenopause, I found it very challenging because I was also experiencing pelvic organ prolapse at the same time. So at about the age of 46, I was first diagnosed with a first leading to a second degree prolapse, and then by the age of 49, I had been diagnosed with a third leading to a fourth degree bladder and uterine prolapse. And the impact that this was having on my bladder health was that I was having difficulty with starting my urine stream. It would stop and start, stop and start. The urine stream would shoot off in all different directions. I had difficulty fully emptying my bladder, and I'm assuming that most likely the reason for this was because of the bladder descending and kinking my urethra. So then I had surgery for prolapse repair and a hysterectomy. And after that surgery, that was when my incontinence issues started to become evident, where I had leaking with coughing, sneezing and laughing. And I also had issues with not making it to the toilet in time.
Wow, that's an amazing journey to go on.
Yes.
So then when you actually, I know it was hard for you to know when you went through menopause because of the hysterectomy, and obviously menopause is the year that we don't have a period. So it's a little bit more challenging. But did you notice anything different when you were pretty sure you'd definitely gone through menopause?
I think it was just the ongoing issues with the incontinence and also the issues with prolapse. Even though I had had surgery to try and repair the prolapses, I still have a minor prolapse. And I do think that is because of the injuries that I sustained during the birth of my daughter, where the pelvic floor muscles were torn from my pubic bone. So it sort of has just been ongoing issues with prolapse symptoms and incontinence symptoms.
Wow. So how did you seek help with everything that was going on?
When I was first diagnosed with the prolapse at 46, I talked to my doctor and she suggested that I see a physiotherapist. So I saw a physiotherapist for about 7 months. She helped me to learn how to do pelvic floor muscle exercises to try and help increase the strength of my pelvic floor. At that stage, I could barely feel a flicker. I was probably only about a 1 out of 5 in strength. So she helped me to start trying to increase the strength of my pelvic floor. She also helped me with improving my bladder and bowel habits. And then after surgery, I continued to see physiotherapists over the last 12 years. I'm now up to my 6th physiotherapist, and they've all been extremely helpful in my rehabilitation. And my GP more recently arranged for me to go on an enhanced primary healthcare plan to help subsidise the cost of all the physiotherapy visits.
Wow. Okay. And you've described a really long time frame. So I suppose it's interesting to know, your journey's been quite long, but it'd be interesting to know, at what time did you feel you had improved control and how long has it taken?
It's taken a long time for me to get control. I think, like I said, that's a lot to do with the fact of the injuries that I sustained during childbirth. But I've definitely seen improvements over the years. Initially, it was very slow progress, but at the moment now, I'm actually probably have a strength of about a 4 out of 5 for my pelvic floor muscle strength. I did a lot of work over the years to try and help improve it, including the pelvic floor muscle training. I also utilised a bladder diary to look at my urinary output and my fluid intake and to see when the symptoms were occurring and why. I learnt how to do the knack and the brace if I was about to sneeze or cough or laugh to try and help prevent any leakage. I stopped going to the toilet just in case. I just make sure that, if I have to go to the toilet, there's been a long enough time between toilet visits to make sure that when I go. Also, I try to stay well hydrated, and I also use the colour of my urine to sort of monitor that. And I've also worn support garments that sort of give extra support to the pelvic floor. So I've utilised a lot of different tools over the years to help manage my bladder and prolapse issues.
Wow. And so how did you keep motivated throughout all this period?
Because I kept seeing little benefits, I could see the improvements, and I knew that it was going to take time. There wasn't any quick magical fix, that I had to be diligent and just keep working at it. And I knew that as I aged, things would become even more difficult. So it's like, I would say, a lifetime habit that I've had to incorporate into my healthcare plan of making sure my pelvic floor muscles stay nice and healthy and that they can function as well as I can get them to.
Wow, that's amazing. And what was the impact of the incontinence when you were experiencing it?
Emotionally and mentally, it had an impact because, like I said, I was also experiencing pelvic organ prolapse at the same time. So that was quite challenging. The financial impact also was quite severe because of the cost of surgery, follow-up appointments with specialists, and then the ongoing cost of physiotherapy appointments. Unfortunately, there are quite a few out-of-pocket expenses, so that has also been quite a financial burden.
Oh, wow. And did you ever call the National Continence Helpline in your journey?
Yes, I did actually. Only a few years ago, I was an admin within a private Facebook support group for women experiencing prolapse and incontinence. And so I contacted the National Helpline and talked to a continence nurse specialist just to try and find out what sort of help and support they could provide. And then I shared that with the other members within the support group.
Wonderful. Thank you for doing that.
That's okay.
And have you used any of the resources of the Continence Foundation?
And yes.
And which ones were they?
Yes, definitely. Once I became fully aware of the foundation, I looked into their website and just looked at all the information they had available, especially in regards to prolapse and continence issues. And I also started reading their Bridge magazine because it had lots and lots of information and lots of articles about people going through similar experiences.
Wow. And how's your life now?
It's pretty good. I still have the occasional challenges, but I have the knowledge and the tools in my toolbox to learn how to deal with any symptoms I might be experiencing. I'm really happy with my progress, and so is my current physiotherapist. I'm still working on my pelvic floor function and strength, and I probably will continue to do so for the rest of my life. About 18 months ago, I stopped the use of panty liners, which was very exciting. And just recently, I experienced COVID for the first time, and I didn't have any leakage. So that was a big win for me.
Wow, that's very impressive. And what advice would you give people who are going through changes relating to their bladder control and are experiencing menopause or perimenopause?
Definitely seek help and support. Don't suffer in silence. Reach out and speak to the Continence Foundation. Look at the information they supply. Contact the National Helpline and try to get an understanding of what is happening and why, so that you know what to do to help yourself. Another thing that I found very beneficial for myself going through all of this was that in addition to exercising my pelvic floor, I also incorporated whole body exercise. So initially I started off after my surgery in a heart moves class, and that was really helpful, and I was able to just modify certain movements to suit my own situation. Then eventually I joined a Zumba Gold class, which is a slightly modified form of Zumba, and I absolutely loved it, and I did that for very many years. And then more recently, I've started an aerobics class, and I find that really enjoyable, and all of that gives me the motivation to keep exercising. And just recently, I've started to incorporate little star jumps and hops and skips into my exercises and haven't had any instances of leakage. So I'm very, very excited about all of that.
Wow, you're an inspiration, Bronwyn. That's amazing. Can you also tell me a little bit about your involvement in the Continence Consumer Network?
Yes, a few years ago, I decided to contact the foundation to see whether they'd be happy to help raise awareness of pelvic organ prolapse during Pelvic Organ Prolapse Awareness Month in June, which they very happily did. And they also asked me to share my journey within the Bridge magazine. And after that, I was then asked to join the Continence Network. And I was then able to give feedback to the foundation about their website, their helpline, complete surveys, and now be involved in this webinar.
Wonderful. And if anyone else is interested in joining the Continence Consumer Network, we'd love to hear from you. Thank you so much for that, Bronwyn. We've got one more poll, which we want to know how many Australian women are estimated to be living with some level of incontinence. Do you think it's 1.2 million, 4.8 million, or 7 million women? So it's really interesting because, you know, it really is a women's health issue when it comes to continence. So we're really interested to see what you think, because I think we would really want to highlight that with this particular webinar to sort of show the impacts that women go to, and particularly a woman like Bronwyn who's had, you know, traumatic childbirth experiences as well as, you know, changes with menopause, to sort of show that the impact of incontinence that actually occurs with us ladies. So I'm just waiting to hear what everyone thinks. Oh, everyone's right on target. So yes, unfortunately, 4.8 million women experience incontinence. So as I mentioned, women are significantly more affected than men. And we sort of estimate that 67% of the population with incontinence are ladies. So us girls are really doing the heavy lifting. And this is regard to urinary and fecal incontinence. Our next presenter is Libby Oldfield. So I'd like to introduce Libby. She's a specialist women's, men's and pelvic health physiotherapist at Beyond Fitwise. She has a special interest in the health and wellbeing of older women, developing programs, conducting classes and giving talks to the community. Pelvic floor, safe exercise, bladder and bowel problems, continence and pelvic pain are major interests of Libby. Libby loves helping people to achieve their goals, and she's a very experienced pelvic health physiotherapist. I'd like to hand over to Libby to give us a presentation on menopause and continence from a pelvic health physiotherapist perspective. Thank you, Libby.
Thanks, Janie. Oh, yes, I've got the slides working. So let's talk menopause and continence, which is the title of this talk. And you'll notice that I'm talking about continence as opposed to incontinence. We will come to that shortly. What's the connection? Let's explore that. So if we just talk about menopause, and Bronwyn's touched on this and so has Janie, but the official definition of menopause is 12 months without a period. But as we know, there is this period of perimenopause, which is the lead up, and this varies, but it can be for quite a few years before you actually have that 12 months. And I guess the challenge with that definition is we actually don't know that we're menopausal until a year after we are, because we have to wait. But there are all sorts of issues that can crop up in that lead up because of the way our hormones are functioning. And we will talk about that more in a second. So perimenopause is where our estrogen levels start to change and fluctuate. So they don't actually just fade away, but they really follow quite a wobbly path until we actually stop producing them. And estrogen is one of our main female hormones, and we'll talk more about that in a minute. So we stop producing estrogen at menopause, which is a bit of a bother because we really quite like it. It's stored in our fat cells. So one positive thing about having fat cells, the more of those we've got, we've actually got good estrogen stores for a little while. Our estrogen receptors, though, in other words, where the cells that pick up our estrogen are in pretty much everything, all our connective tissue, our muscles, the smooth muscles, which are the muscles that are, for instance, our bladder wall or our bowel wall, things that we can't control but are actually very necessary. So estrogen, as I said, is one of our female hormones. The other big one is progesterone, but we won't talk about that today. It regulates our cycles, and it's absolutely essential for fertility. So fundamentally, what's happening at menopause is that we cease to be fertile. And to be honest, I think Mother Nature loses interest in us a little bit at this point, which is why we start having a few more issues. But because we can't have babies anymore, we're less important to her. So estrogen enriches our connective tissues, our bladder tissue, our bowels. It actually plumps up the walls of all your smooth muscles, so your arteries and your veins. It just keeps everything working really well. Estrogen is also the main hormone that produces the lubrication that we need in our vaginas for sexual comfort. So it's pretty important. So let's talk continence then. So the official, unofficial, my definition of continence is that it's the control of the contents of your bladder and your bowel until you're ready to do something else with them, right? Imagine if we didn't have taps, then we'd be no different to an animal, would we? And even then, we know that some animals are trained with higher brains. So incontinence then is the accidental loss of urine or wee on effort or physical exertion, which includes sporting activities. As Bronwyn mentioned, things like coughing and sneezing are often when you would notice that form of incontinence. It can be associated, though, not with those things, but with the bladder urgency, which is a sudden, strong urge to wee, where you suddenly go from not thinking you need to go to the toilet to absolutely busting, and that urge can be so strong that you actually start to wee without being able to control it. So that's pretty uncomfortable and not something that we like to experience. Often these two present together because they have different causes, and one doesn't necessarily mean you don't have the other. There are actually officially, according to the International Continence Society, 11 different forms of incontinence, but we really need to just focus on these two. So stress urinary incontinence, urgency, frequency and urge incontinence of wee and or poo, unable to control wind, fecal or poo smearing or leaking. So, you know, for instance, if you notice you have skid marks on your knickers after a poo, or you worry about that, or you develop some urgency when you need to use your bowels and you can't get to the loo in time, all these things are related. There are other issues to do with this part of our bodies as well, which we're not going to talk about today, but Bronwyn's alluded to pelvic organ prolapse, but pelvic pain, sexual pain, anything that's going wrong in your pelvis has usually going to affect your bladder and your bowel because they're the main occupants of your pelvis. So why does it happen? So the three big risk factors are pregnancy and childbirth, and I think Janie's got a fabulous statistic that says it's 1 in 3 women who've ever had a baby. Now, interestingly, the biggest risk of all for continence is being a girl. And I think we've learnt that in the frequency of the poll as well. So you can't change that. You're a girl, and I'm sure you don't want to. The next biggest risk is actually being pregnant the first time. So it's not actually the birth, it's actually that very first pregnancy when your body for the first time has to carry all that weight around. And it goes under the very fancy name of being called tissue creep. That weight of the baby sitting on all those structures in your pelvis is providing a really constant, slow stretch. If any of you have ever done yin yoga, you'll know what that feels like. So then when we give birth, that is an insult on top of that. So it's sort of like a super sprained ankle on top of a structure that's not working so well. The muscles in your vagina when your baby's head is going past actually stretch 2.7 times their resting length, which sounds a lot, but quads and hamstrings like to go 1.4. So it's quite a big stretch, and that's if you're having a vaginal birth, of course. I should have also pointed out the risk of incontinence after pregnancy and childbirth isn't much different whether you've had a vaginal birth or a Caesar, but it's obviously very different in terms of pelvic organ prolapse, for instance, if you've had a vaginal birth rather than a Caesar. One of the other big risk factors is constant heavy lifting. So we can just say being a mum, because we're carrying around our babies for such a long time before they're independent. But it's obviously other heavy lifting as well. Supermarket bags, for instance, we've all forgotten that 2 litres of milk is actually 2 kilos. So if we put in 2 litres of milk and 2 litres of juice and a couple of other things, if I gave you that weight in house bricks, you'd all tell me it was too heavy. But if it's a smiling child, we don't think that, of course. Training, as in exercise training, is showing to be another big issue. And with this level of training, to not put you off exercise, because you'll never hear physios doing that. But if you're an elite athlete, when we're actually discovering that some of our seriously elite athletes, like trampolinists and netballers, the ones that train all day, every day, are starting to create a few problems as well. Constipation is the other big risk. So the top 3 are the big 3, right? Now, constipation and constant straining, not pooing correctly. There is an art to pooing. All of those things play heavily on your risk of incontinence. And then the other things I've put there, things like stress. So when we talk about urgency, for instance, and we haven't got time to do this today, but urgency is actually coming from your brain. It's your brain saying to you, listen, your bladder's full, time to go and empty it. But sometimes your brain can go a little AWOL and it can worry about you because it's detecting you're already worried about other things. So stress can play a big part in that urge incontinence and whether it's of urine or bowels. Recurrent urinary tract infections are often another issue because if you've ever had one of those, you'll know the symptoms aren't pleasant, and that tends to make you want to go to the toilet more often, which then tends to become a bit of a habit. And Bronwyn mentioned before about no going just in case, but that's often one of the big disservices we do to our bladder, but more about that another day. And because we're here today, we're talking about ageing tissues, and the big thing about our ageing tissues is our no estrogen, so our muscles aren't quite as strong, although the good news is you can still strengthen them. Our tissues are less elastic because of our estrogen disappearing, so they're easier to damage, they're slower to heal, and generally getting older sucks, but never mind, we're all doing it. So how to get help, and I think Bronwyn's talked a lot about this as well, but the bottom line is tell someone. One of the things we find often is that you've perhaps asked your mum and she said, well, that's normal, dear, because I've had a baby too, but it's not normal and there is always something you can do. Even just chatting to another friend. Those of you who have bumped into pelvic floor physios will know that we're not backwards about coming forwards and discussing all things, and it's often a hot topic over lunch, much to the amusement of the other people I work with. You can see your GP, you can see a pelvic floor physiotherapist, you can look up the Find a Physio website. Pelvic floor physios are tertiary trained physios, so they're not just physios who've done a physiotherapy qualification. They've all done a lot extra training because this is quite a complex area. But there are, in the big areas at the moment of our metropolitan areas, there are quite a few of us around, but we're also good at telehealth and things like that as well. As Janie's mentioned, call the National Continence Helpline and they have all those resources at their disposal. And the really important thing that I want to get across today is that all of these conditions can either be cured or improved significantly. So there's never anybody for whom nothing can be done. So treatment options. So the correct diagnosis is very, very, very important. And as I've already alluded to, there are different sorts of incontinence, and managing them requires different things. For instance, if we're talking about pelvic pain, which we're not really today, but just to point out that a lot of women actually don't recognise that your pelvic floor muscles are actually your first responders for stress. And a lot of people accidentally learn to hold on to their pelvic floor muscles and never give them a chance to relax. And that ultimately leads to things like painful intercourse, just pelvic pain, all sorts of things you don't really want. So, for instance, if that diagnosis isn't made correctly and someone provided you with a pelvic floor strengthening program for that sort of problem, you would actually make it worse. So getting a correct diagnosis is super, super important. But your treatment will include things like some form of pelvic floor exercises. In that previous example, it's about teaching the muscles how to relax. But often, as Bronwyn said, strength is the problem. It's not just strength, actually. When physios think about muscles, we think about their ability to be able to contract well and strongly, but we also need them to hang on for as long as we need to. We call that endurance. And as I said, we need them to relax properly as well. So sometimes the treatment will involve bladder training. Sometimes it's as simple as just getting started with what are good bladder and bowel habits, which includes things like diet as well, obviously, if we're talking bowels. Topical estrogen is an extra estrogen that you can pop in your vagina, and we can, that's a doctor type conversation to have, but for most of us, it's very rare to not be able to use topical estrogen. And for a lot of women, that actually makes a huge difference to the health of your bladder and your urine pipe, your urethra, and all of those things that our body used to rely on. There are some aids and devices, and if you Google these things online, you'll find a lot of things that are very expensive as well. But again, they need to be used in conjunction with somebody who knows what your diagnosis is. Otherwise, you can be spending a lot of money and not gaining much. And there are also different surgeries that you can have. So these things are sort of possibly in the order in which you'd want to try them, in that surgery should be a last call thing rather than a first call thing. So a typical first appointment with a pelvic health physio is usually an hour, so we have plenty of time because we're trained to listen to your story, hear how much it bothers you and what's happening to you, and we can use all sorts of different things to assess as well. Often we'll get you to do a bladder diary or a bowel diary or keep an accident diary, for instance, and you usually come back having done that, telling us how much you've learnt from doing that. So depending on what happened, what we find, treatment, you'll be given treatment, a management plan and a timeline for recovery. So just a guide to treatment timelines. If we're just talking about strengthening muscles, you can do a lot in 6 months, but only if you do your exercises. Bladder training and urge suppression take a bit longer, but again, they're skills that you need to learn and do and be able to do. Bladder and bowel habits can only take a few weeks with a bit of guidance on what's good, what's not. And as a general rule, you don't have all that many appointments with a physio, with a pelvic health physio. I know Bronwyn's been different, but if it's just about muscle strength and incontinence, you'll probably have 2 or 3 appointments pretty close together, but then after that, it'll be more a check-in to see how you're going. The research tells us that regular check-ins with physios, you know, every 6, 12 weeks, 6 months, whatever, makes a big difference. And there's always something you can do to help, all right? So please, please get some help. Thank you.
Wonderful. Thanks, Libby. If it's okay, I'd love to ask you and Bronwyn a few questions because as I mentioned earlier, we had a few questions from our attendees that were sent in advance of the webinar. The first question, if I can ask you, Libby, it's about estrogen, topical estrogen,
Right.
which you just mentioned. So is it recommended for women with urinary incontinence who have or in menopause or perimenopause age for their doctor to prescribe? And if so, how is the cream best applied? You know, some have applicators, some are tablets, some are creams, or can it also work well if you just topically rub it or apply it to the external urethra?
Okay, that's a big question. And the first answer to that is that this is a conversation with your doctor. All right, because your doctor has to help you understand that. But sometimes you can go to your GP, and asking the question prompts them to think about it. So that's also really useful. It's actually, because when we say topical, we do mean put it in your vagina. So to answer that last question first, just rubbing it on the outside's not that successful. But putting it inside your vagina actually gives your estrogen health back to just that part of your body. One of the advantages to topical estrogen is that it doesn't go through your whole body like having patches and things. Now, as a general rule, it's not given to you straight away because it takes a while for your estrogen to wear off. And your doctor may well have prescribed what we call systemic estrogen, which is where you have a patch or a tablet, to get you through the perimenopausal period and for a couple of years afterwards. But we have learnt from all the research that we can't just stay on estrogen forever, even though we'd all like that. So the next best thing is talking to your doctor about the topical estrogen. There are two main sorts. One's called Vagifem, the other one's called Avestin. The Vagifem is a very low dose one, comes with a little single-use blue plastic applicator. By far the easiest one to put in, but probably the least effective. Again, it's a question to talk to your doctor about. The other one, Ovestin, comes as a sort of a big pessary pill you pop in your vagina, or another sort of applicator in a cream to help you put it right into your vagina, and that's the best way to use it. But talk to your doctor.
Thanks, Libby. Another question for you, Libby, regarding exercise and weights. This person has started going to the gym and always concerned about exercises putting pressure on her pelvic floor. She does pelvic floor exercises 5 nights a week. And once you have a weak bladder and in menopause, do you still need to keep doing these pelvic floor exercises forever?
Okay, so yes to exercise, absolutely. And the research world is a physio's dream at the moment, because every single thing that goes wrong with us is improved by exercise, and more recently, spectacularly, for prevention and management of recurrence in cancer. So that's a whole other topic. Yes, you do need to have strong pelvic floor muscles for the rest of your life. And how you get there is going to be something you can decide with your physio. You're fundamentally in the gym, you're only as good as your weakest link. So if your pelvic floor isn't crash hot to start with, you need to get it to a level where it is. And things like clinical Pilates with a physio can help train that, so that when you're lifting a heavy weight in the gym, you need to be thinking, am I controlling my pelvic floor? And hopefully the answer is yes. And you can continue to do that. You should never get bladder or bowel symptoms as a result of exercise. So if that would be what I would call a yellow flag, if you like, get some help. The other thing is that you do actually need to keep doing pelvic floor exercises. To begin with, I wouldn't do them at the end of the day because everything's tired. So to get the best out of it, you do them standing in the shower in the morning, because standing's harder anyway, so it's a good test. And you don't need to do them 5 nights a week even to make them stronger. Strength training is something where we overload the muscle. Doesn't matter whether it's pelvic floor muscle or your quads. If we overload them, we need to give them a day's rest. So in fact, we know if you're doing a really good, strong pelvic floor contraction, that someone has ascertained you can do, then you really only need to do them 3 or 4 times a week. But if you seek help, we can help you put pelvic floor exercises into the rest of your day. So otherwise I'd agree with you, sitting doing pelvic floor exercises all by themselves is really boring, and you can't see what you're doing, so you don't even know if you're getting any better. So there are lots of other ways to exercise, and people like me can help you find those. So definitely keep going with the exercise.
Fabulous, Libby. I agree, because we're all got our own pelvic floor and everyone's unique.
Yep.
So you can't all do the
Yep.
same thing. So you really got to find out what your strength and stamina is and endurance, and work with that. Fabulous.
Exactly. Yeah.
Can I ask Bronwyn a question? If I can ask you, Bronwyn, what would you suggest to this person who's written in? How can I help myself? What would be your hot tips with regard to that?
Yep, definitely start talking about it. Seek help and support, and whether that's contacting the Continence Foundation, talking to a continence nurse specialist, looking at their website, looking at all the information that they have, seeing if you can access the help and support from a pelvic floor physiotherapist. I highly recommend them. Just find whatever you can that you can do to help yourself.
And you've talked about your Facebook group.
Yep.
So I gather are you quite open with chatting about what you experienced with your friends and family, and how did you go about that?
Initially, it was I found it challenging to talk about, but the more I started talking to my close family, then gradually my extended family and friends, and then within the support groups with women that were also experiencing the same thing, it became so much easier. And now I just talk openly about it. And then that, I think, then encourages others to be able to talk openly about it and to seek the support that they need.
Wonderful. Thank you. Just to let everyone know that we are continuing the webinar to 1 o'clock. We understand that some people may need to leave at 12:45 or in a minute, but if you're able and interested, please continue on, because we will continue for another 15 or so minutes. Libby, I know you've slightly answered this question already, but I'm just going to ask you another question, if that's okay. Is the lack of bladder control since the age of the early 50s a permanent thing that we have to live with?
Absolutely not. Absolutely not. The correct thing there is to find out why the bladder feels weak. And it can be a whole variety of things, and it's usually a series of ducts that need to line up. So you need to drink the right amount of fluid, you need to go to the toilet the right amount of times in the day, and obviously there's not one magic number there's a selection. It's about understanding how you work, and that's where learning about how you work is really important. But no, I would totally think that can be significantly improved. And as I've said before, it doesn't matter. We know things happen as we age, but we also have good research evidence now to show that exercising differently, but exercising still improves our muscles, even if they feel like they're getting a bit weaker. So the biggest issue is not doing anything.
Yeah, I must say, even for pretty much every health issue, any sort of exercise is really positive, isn't it?
As I said,
even
it's
for
a
dementia, for example.
It's a physio's dream in the research world, because everything has an exercise solution.
Yes, which is great.
Yep.
Lovely. Bronwyn, if I can ask you a question, how do you think we can better educate women on pre-wee problems and get the conversation into the open rather than being embarrassed?
Pretty much the same as what I said before. Start talking about it. The more we talk about it, the easier it becomes. And then finding out where you can get the support and the information that you need to be able to help yourself, and to pass on that information and support to the women around you so that they know where to go.
How can we tap in before it happens, though? Do you think that that's in the, when you're pregnant, or?
Yeah, I think knowledge is key. So learning about our body and what can go wrong with our bladder and our pelvic organs, and everything else in general is so important. So I think education prior to all of this happening and information prior to all this happening then makes it so much easier to navigate when any of these sort of issues start impacting you.
Yeah, so true. Thank you, Bronwyn. Sorry, another question for you, Libby.
Mm-hmm.
How can we reduce trips to the bathroom overnight and get less interrupted sleep, which I know is a big issue for many people?
Right. Well, the first thing is to just look at what you're drinking and then to look at when you drink, right? There are two things about interrupted sleep overnight. The first one is that it does depend on how much fluid you've put in. And we know some fun facts now, for instance, that carbonated drinks, even soda water, can make our bladders a little bit grumpy. So it might be looking at what you're drinking as well. We obviously know that alcohol plays a part there too, but we won't go there today. So if you're really getting up quite a lot at night, the first thing I would suggest is that you don't drink after about 7 p.m. Which means you have to have had your daily intake before that. The next thing is that when you are asleep for the first couple of hours, your brain actually finally says, okay, we're asleep now. So it actually releases a hormone that tells your kidneys to slow down, so that we are designed to be able to sleep for more than the 3 or 4 hours between toilet trips that we usually do during the day. If you don't have that solid couple of hours to start with, the hormone doesn't get released and then your bladder fills up, right? And then you do need to empty it. The other thing to think about is that just because you've woken up doesn't mean you need to go to the toilet. And probably you've inadvertently trained yourself to do that as well. So that you wake up and you think, oh, I better go and have a wee, and you do that and then come back to bed. Now, at menopause and after, we accept once a night as normal, as long as when you get back into bed, you go straight back to sleep. In other words, it's not disrupting your sleep. But if you've done all the other things, like you've thought about how much fluid you're drinking and when, and then if you think you might be in a habit, one of the ways of assessing that is to sort of look at the time you wake up and pretty much discover it's probably a similar time. And you can start training yourself with a bit of help to extend that time and get yourself to the morning. So again, lots of things you can do to help.
Yeah, I think nocturia, getting up to the toilet at night, can be a really, really tricky thing, and you can fall into that trap. And there's also, you probably have to look beyond menopause and perimenopause as well. So if you've got any other health conditions, if you've got some sleep problems, maybe you do a sleep study, that type of thing. So you have a chat to your GP as well as a continence professional, because it could be multifactorial as well. So don't just assume it's perimenopause. You know, do sort of go, okay, this has changed. Not everything is going to be related to menopause, but menopause is generally not going to help.
Yep. No, you're quite right.
Is there one thing, Libby, that you think every perimenopausal person should know about bladder control during this stage of life, and before they get there, so leading up to it? What's a thing you should really think we should be prepared for?
Well, it goes back further, and I think we alluded to that before, but the World Health Organization suggests that every pregnant person the first time should have access to some pelvic floor knowledge around the world. And that obviously is a bit of a pipe dream. But if you think about it, we actually have less information now. I know we have Dr. Google, but that information's not clear. So if you've been pregnant, you know that you've dropped yourself into that risk basket of potentially having a continence problem. So the ideal time to check pre-menopause or even before perimenopause is to have a pelvic floor check and see what you're doing and see what you can improve. And while you're doing that, you should also have a bone density. It's really good to have those things pre-menopause because we know they're affected by our hormones. So understanding how to contract your pelvic floor muscles correctly, 25% of us get it wrong, apparently. And it's also because we can't see them, so we don't know what we're doing. So that would be my first and biggest suggestion, if you like, before you get to perimenopause, but it's not too late ever to have a pelvic floor check.
I think it's interesting too, because in the media at the moment, a lot of women's health issues are kind of dismissed. And it's sort of interesting to see how can we have a voice, because I know there's a lot of focus on, encouraging men to go to the doctor. And although women present to the doctor, we don't always get a voice there. So it'd be interesting to know, what do you think we should say? Because I know I currently tell my GP what I want these days. What do you suggest if someone is in that situation? What should they ask for or say?
Yeah, okay, so if you're having any sort of symptom in that part of your body, like the occasional leak, you can't control wind, you're worried about getting to the toilet to use your bowels on time, any discomfort, any pain, any heaviness, any dragging, then the first question to your GP is, should I get this checked out? Hopefully you're not dismissed. But as I said, one of the big things is that physios don't require a referral. So you can actually go to a physio and ask. And we won't ever tell you that there's nothing you can do, because there's always an exercise you can do, all right? So you will be listened to, you will be heard, and you'll have a program that suits you. So I would definitely run everything past your GP, absolutely. We have a good collaborative relationship with all your doctors. We all communicate with your doctors. We obviously do that with your permission, of course, but once you've told someone, there will be more ways that people can help. But I guess what I'm really saying is, if you feel vaguely uncomfortable in that part of your body for any reason, there'll be something you can do to help it once someone knows what it is.
Wonderful. I'm going to ask Bronwyn that same question. That is, what is one thing every perimenopausal person should know about their bladder control before they enter that stage of life? Is there a tip that you'd also give, Bronwyn?
Definitely consult a women's pelvic floor physiotherapist. They're worth their weight in gold, and I can't recommend them highly enough.
Wonderful. That's fabulous.
I think, Janie, the one thing is that none of these things are normal. They might be common, but they're not normal. So getting help is the most important bit.
And I think having that voice and that understanding, go and speak to someone, open up that conversation, and make sure that you're clear in this isn't, I'm not comfortable, I need this to be looked into. I'm going to ask you, Libby, is there a difference when someone goes through surgically induced menopause compared to probably a more naturally progressed menopause?
Fundamentally, no, unless the surgery also affected your ovaries. If you've still got your ovaries, then you're still producing estrogen so therefore you're still going through perimenopause and menopause. You just won't have the bleeding sign to tell you that, right? So that'll be the main difference, but otherwise menopause is the same. So if for some reason your surgery involved removing your ovaries as well, and that's not as common, usually they try and hang on to your ovaries, but if your ovaries have been removed, then all of that happens quite quickly at whatever time you stopped having ovaries, all right? But otherwise, it's just the same. You just don't have the signals of bleeding to tell you where you're at.
And then another question for you, Libby. If you've had a sling put in years ago and now are finding you're having problems with continence, does exercise help?
Yes, but that should be assessed. Because the biggest problem is that if we don't move it, we lose it. Right. And as we get older, our muscle tone deteriorates much faster than we used to. Right. When we're 25, we take everything for granted. But as we get older, we have to work harder to stay in the same place. So the sling's put in for a particular reason. It's usually for stress incontinence, but that doesn't mean you can't get urge incontinence or any of the others. So again, getting some help, getting the correct diagnosis, and then there will be things you can do to help.
And with regard to pelvic floor exercises, because occasionally we hear ladies on the National Continence Helpline saying, I've done exercises and they didn't help. But I always say, but did you use them when you needed to? You work to improve your strength and stamina, but you also need to do more than that, or else they've just, read about them, did something online, never actually consulted someone.
Yeah, Janie, one of the big things here is that sometimes I don't know whether they're still on the telly, but there used to be lots of ads saying do pelvic floor exercises at the petrol pump and all of those sorts of things. Pelvic floor muscles are skeletal muscles, so that means they're the same as quads and hammies. And the only way your brain gets a message to make them stronger is if you do a training set. So you have to actually exercise. When you sit down to do your exercises, you have to have a session. So you have to contract and hold and let go the way you've been instructed until those muscles get tired. If you don't do that, if you just do one here and there or one at the red lights or whatever, you're not actually telling your brain to make them stronger. So that's usually the thing that we find when we finally meet you, is that you haven't been doing the exercises correctly. As I said, 25% of us, according to the research, are doing them wrongly, actually buried down like they're going to have a baby, which is not helpful. But the biggest mistake is in that training load. And there has been a lot of advertising in the past about, you can do them anywhere, which is true. You can do them sitting on the tram, but you actually need to be concentrating on what you're doing. And if you were doing sit-ups, you wouldn't also be driving a car or putting petrol in the car. You've got to be focused on what you're doing. But having said that, if you're going to do, and this is just a pluck out of the air, this is absolutely not a prescription for anyone listening, but if you were going to do 10 by 10 second holds, if you do the sums, it's still only 100 seconds. Like, it's not a big chunk out of your day. There are ways to fit it in.
Yeah, and that's really interesting. I'll be interested to hear from Bronwyn how she incorporates her pelvic floor exercises into her day. How do you do it, Bronwyn? Like, do you set a particular time each day to do it, or how do you incorporate that?
Yeah, I try to have a routine that I do them at a certain time of the day, certain days of the week. I don't get so obsessed if I do happen to miss any. I just make up for it as I go along. So I just incorporate the exercises in my daily tasks. So if I'm going to lift up something particularly heavy, I'll engage my pelvic floor appropriate to the task. And also when I'm doing my exercises at the gym, I will do the gentle pelvic floor contractions appropriate to whatever movement I'm doing, to try and make sure that I don't have any leakage problems, and also that I'm exercising effectively.
Amazing. Can I just say, Janie, that the way Bronwyn's describing that is exactly what you have to do. You have to have the tools, so you have to have muscles that work, but the tools are to help you live your life. So that the way Bronwyn's describing, doing a gentle contraction depending on what she's doing at the gym, or lifting the soup pot or whatever, it's about understanding what role those muscles play and when you need more power and when you need less. So well done, Bronwyn.
She's an inspiration. Thank you, everyone. This has been amazing. I've found it very stimulating. Thank you so much to Bronwyn and to Libby. You've been amazing, wonderful presentations, and I've learned a lot myself personally, being, I think, in the year of menopause. Wait, I'll be able to tell you in about another 6 months' time if you really want to know my personal details. I'd also like to thank the Continence Foundation of Australia for putting this webinar together, and also the team at Logic Events. And I especially want to thank Joanne Sinclair. She's one of our health promotion team members at the foundation. She's done so much work in getting this organised, and it's been amazing. She's been such a wonderful person to work with. Thank you, everyone. Don't forget, there is a survey at the end of the webinar. If you can hang around for a couple of seconds after it closes and just give us some feedback, that would be greatly appreciated. But thank you again to Libby and Bronwyn. Amazing, really, really useful and inspiring information today. Thank you both.
Thank you.
Thank you.